So we've got maybe less time than we'd hoped for the panel discussion, but we have 5 minutes. So does anyone have any questions for any of the speakers from this afternoon? We wowed you all into silence.
Oh, there's a lady at the back. Lady at the back. She's taken it.
Hello, and thank you for the lecture. I really enjoyed it. My question is, when is it more likely that a child would not have the shaking baby syndrome? Like from what age? Because I think I have a case at the moment, but the child is 3. Haven't been shaken before, but at 3, I don't know, is the child still liable to sustain a shaking baby syndrome?
Do you want me to? Yeah, it's about 3 to 5 months is the normal age for, and it's to do with the weight of the head and the head lag, and that is what causes that acceleration and deceleration. And if you,
yeah, I mean, so yeah, that's the sort of age range that we typically see it in. I mean, I suppose you can never say never,
no.
And you know, as Lynsay said, part of the issue is that you don't ever really get a proper story of exactly what has happened. Personally, I would say 3 is maybe a bit on the older side, but you know, nothing's ever really impossible, I think.
Yeah, the child is not frail, but on the little side, and the person is quite a huge gentleman. So we're not quite sure, but that was the first time they met themselves. So he didn't meet the child prior to him becoming 2.5 years to 3 years old.
They are really tricky cases, like we said earlier, but you know, I think as health, our job is to make sure the patient's looked after. It is a massive team. You have police, social work, and whatever. You know, I guess it's part of the police job is to investigate. You know, health can provide a report as to what they think and what they see, but again, it's definitely a multi-agency decision. And again, you know, it's almost like police for to decide, you know, the criminality around it. And again, at 3, we sometimes would find that a 3-year-old would be able to tell you what had happened. Do you know, again, it's really difficult in that age range that we talked about, under 6 months, because they can't speak, they can't vocalise. We're relying on parents, but by 3, and maybe at nursery and things like that, we would expect them maybe to hopefully be able to tell you at least something.
And sorry, just to come back on that, the injury pattern, as we've talked about in lots of talks today, is that sort of momentum and then the stopping. It's that deceleration. So you know, there are other mechanisms that can happen. You know, hitting against something would be the thing that comes to mind. So it might not be that classical shaken baby, as we've said, for those reasons, but that sort of acceleration, rapid deceleration mechanism can happen at any age.
And it is really easy if you know, the patient already has had a previous shaken injury, but like kids do have accidents, so you know, again, it's like looking at other causes. Is there other causes for it as well?
So obviously when you see different cases, there'll be some cases for you which are dead obvious for abuse, and maybe some cases which are dead obvious that there's no harm deliberately caused. But I'm curious about the cases that are in the middle, the tricky cases you're describing. Does the presumption favour the welfare of the child, or does the presumption favour keeping the family unit and giving the parent the benefit of the doubt?
The welfare of the child.
Yeah.
Always first, yeah.
That's what I thought.
Yeah. And again, it's really tricky, you know, again, we'll hark back to multi-agency things. You know, social work, certainly in Scotland, have the final say. You know, we as health provide all the information, but in terms of, you know, foster care, that sort of type of thing, you know, it is definitely a multi-agency thing, and it's about, you know, that is the importance of communication. It's about everybody coming together, you know, and hopefully everybody has the welfare of the child at the heart of it. But, you know, we don't always see that, but that is, I would say, what 90% of us aim for.
I know there are people in the room who've got a lot of experience in assessing maltreatment later in a child's kind of age, and it does become very complex. I think that most of the conversation today has been around the kind of infant onset, because there's such a kind of large number. But obviously, child abuse and neglect can happen at any age, and I think it can be similarly complex trying to, prove causation and also how we intervene and how we stabilise things for children and families. So it's a very complex area.
It's also, neglect is also really difficult to define as well. Do you know, like, what one person says is neglectful, another person might not, do you know? And I think, in different social work teams and things like, everybody has different thresholds. So then, again, it then makes it even more complex to define.
I think for me, the important phrase, and it's a little bit overused, so I sort of hesitate to say it, is professional curiosity, really. Just keep asking the questions. Don't assume one thing or another. Keep checking. We've had some cases where I work at the moment where you'd think, there's no way that would happen, but whoever was there at the time thought it did and just didn't keep asking those other questions. Real critical analysis of it. I think that's really important.
Okay, any last questions? And down at the front. Okay.
Cheers, hello. I wear two hats, so I'm an occupational therapist but also case manager, and kind of looking at the other side of the coin, I've had a case very recently where I can see that parents are really struggling. Parents getting very, very close to breaking point, to the point where you're almost preempting a bit of a child protection concern. When we take that to a huge multi-agency team, and again, like you said, social work kind of having that final overarching say, if you like, and them not putting anything in action to kind of help support the parents. And these are parents that are absolutely crying out for help, that are not getting the care and support that they need. It is incredibly frustrating when you have those concerns and you feel that they're just not being taken seriously, and they're echoed around a very big table of professionals, but yet nothing is getting put in place to stop that. I suppose it's just a bit of a comment, but kind of any other advice in that kind of incidence?
I would say it's probably just about repeating that message.
If
you look at all of the inquiries that have happened, whenever these are looked into in detail, there's always been missed opportunities. And in terms of, is everybody's problem, it's everybody's duty to try and recognise it, be concerned about it, and raise those concerns. And I think that's all you can ask individual people to do. It's just that continuing. Yeah, you may have had that case conference, you may have made that decision, but I still have concerns. I think that's all as an individual you can do. You're not in a position to be able to knit support for a family, but just being that advocate for that family, actually we are worried that these are really at risk, and you may have said that they're not, or you may have said that they are, but nothing has happened. And I think that goes across all disciplines as well, social work, health, education as well.
Yeah. Thank you.
And maybe the last question.
Just wanted to say what a lovely joined up session this has been, and it's a very sensitive and difficult topic, isn't it? But you've so beautifully identified the real issues and the vulnerability of wee ones under 6 months and the potential lifelong impact. But then you've circularly brought us around to what can be done in a universal preventative way. It's not going to solve it all, but the results are encouraging from America. So I suppose my question is really, given Maria's collecting this data in Scotland, is there an opportunity for ICON to be, robustly evidenced? If that the data's there now, isn't there, for a baseline? So you've got potentially the follow-up to find out.
Very much exactly it. Because it's gone all at once in Scotland, whereas in England, and it's been here, and it's spread gradually. There is that potential, absolutely. So we're going to have a little chat. Thank you.
It is so interesting. Before I knew Suzanne was presenting today, I actually did have icon slides in my presentation. So, so yeah, you're absolutely right. There is a big opportunity there.
So nice to finish on an optimistic note. So before we close, I've just got a few quick announcements. So last thing is the QR code will appear, and it's important that you register that now because they're time stamped. So if you don't do it now, you won't get the certificate. So remember to do that. Also, that all of the presentations from today in a few days will be uploaded to the Head Injury Information Directorate website. So the HIID website will have all of the presentations, and if you've registered, you can access those. And also just to remind that the next event will be on Tuesday the 14th of September 2027. So it just remains for me to thank all of today's excellent speakers. I think we can agree it's been a fantastic day with lots of depth and lots of breadth of coverage. So thanks to the speakers, but thanks most of all to all of you who've come along. It's a conversation, so we've got some very experienced people sharing their views and perspectives, and a very experienced audience. And I think the conversations that we have is the real value of days like today. So thanks to everyone. I hope you've enjoyed the day. Thanks again to Digby Brown, to Chris Stewart, and to Kirsten Smith. I'm not sure if Kirsten's still here, but fabulous day. Well done, everyone. And we'll hopefully see you in 2 years.